Good evening, everybody. Thank you very much for joining us this evening for our first ever NRAS Live on the topic of menopause and RA. My name is Donna Stenson and I'm the Innovation and Service Delivery Director here at NRAS. And that basically means that I support the team who are responsible for the delivery and quality of our NRAS services. And if I say so myself, they're a very fine team. So the format for this evening, we'll be here for about 60 minutes. We're going to have a presentation from Dr Vikram Talaulikar, lasting about 20 to 25 minutes. In the promotion of this education event, we asked you to submit any questions that you have about menopause and RA. And unsurprisingly, we've had quite a few. So after Vikram has presented, we will go into a question and answer session. So don't worry if you haven't submitted a question yet, you will have the chance to do that later. But just a little reminder, can you not ask any personal medical questions, as it wouldn't be appropriate for us to answer those in a public environment? So that's great. So if you'll allow me to just set the scene before we start talking to Vikram. It has been my privilege to lead this menopause work at NRAS. My background's in women's reproductive health. And when I joined 20 months ago, I saw that NRAS had already been involved in RA research, led by NHS colleagues from around the country. The output of that research was unfortunately not shocking and wasn't great. The standout statistic for me was that 93% of women who answered the survey told us that no clinician had discussed the menopause with them, let alone the menopause in regards to their RA. This just felt wrong. And so we set out to do something about it and improve experiences for women with RA dealing with the menopause. So what's the intention for this work? Well, at NRAS, we're pretty great at producing evidence-based information to inform and support people to self-manage their RA. And we felt it was appropriate to create some patient information for menopause so that people can arm themselves and feel confident to discuss menopause with either their GP or their rheumatology team. We are working with women who use our services, the British Menopause Society and rheumatology specialists to co-create these materials. We have created a patient information booklet called Menopause and RA that will be available to order and download from the NRAS website in the new year. So watch out for more news on that. And just a reminder that if you're a member of the organisation, you'll hear about all those releases first. But we didn't want to stop at just the booklet. So starting with this session tonight, we created some other events to help support and inform people and professionals. So tomorrow, Elsa, our National Patient Champion and founder, and I will go to the British Menopause Society Women's Health Symposium to help spread the word with menopause specialists about RA. Our professional advisor, Elena Nikiforou, consultant rheumatologist and senior lecturer at King's College Hospital, will kindly represent NRAS by talking to the menopause specialists about what RA is and how to support and treat women of menopause age with RA. We also provide lots of peer support here at NRAS and have a programme of online support groups called Join Together. We were told by the women who attended our focus groups that there was no support out there for them when they hit the menopause. They also told us they really value talking to each other in the focus group. It made them feel a lot less alone. So we've created a new Menopause and RA online group, which will be led by a volunteer group leader, Sarah Collins, who is a highly experienced psychotherapist and has also lived with RA for many years. The first meeting is at the end of January in 2026, and you can register your interest to attend that group by visiting our website now. We've actually pinned a link in the chat for you. We'll be using this group going forward as a way to engage directly with women to understand where they think we should go next with our support. So once all of these services are launched, we'll be looking at developing further education resources for healthcare professionals. So that leads us to tonight's event. In rheumatology, as with most areas of healthcare, we have a European best practice conference each year, where lots of experts provide education and information to ultimately improve the health of patients. And at this year's event, the last session I attended was presented by Dr. Vikram Talaulikar. It was a very well attended session by the rheumatology community. Vikram's presentation was all about menopause and how rheumatology professionals can support women experiencing menopause in addition to rheumatology conditions. After the event, Vikram was swamped by people wanting to speak to him further. Apart from being a really great talk, it made me think our community is really interested in learning more. So I thought I'd take the opportunity to reach out to Vikram after the event to ask him would he support us and the patients that we serve by doing a similar talk, and here we are tonight. I was very happy to find out Vikram was hugely supportive of our approach and he agreed to be part of this event. So thank you so much, Vikram, for being here and giving us your time. So without further ado, I will hand over to Vikram, but while he's getting his slides up and ready, I thought I'd give you just a little bit of background into Vikram. He is a specialist in reproductive medicine at University College London Hospitals NHS Foundation Trust and an honorary associate professor in women's health at the University College London. He graduated medicine in India in 2003 and completed his postgraduate degree in obstetrics and gynecology in 2007. He is a fellow of the Royal College of Obstetricians and Gynecologists and completed his PhD degree at St George's University of London in 2016. He is a certified menopause specialist by the British Menopause Society and has been published widely in reproductive medicine and menopause, and is a member of the British Fertility Society, amongst other international membership bodies. He runs a very busy menopause and PCOS clinic at UCLH and Menopause Clinic London on Harley Street, and is the principal trainer for the Faculty of Sexual and Reproductive Health, their menopause module, and a trainer for the British Menopause Society, Principles and Practice of Menopause Care. Welcome this evening, Vikram, and over to you.
Thank you so much. And I hope you can see my first slide.
Yeah.
If you can. Perfect, thank you very much. So first of all, thank you, NRAS and Donna, for getting in touch and giving me this opportunity to talk today. It's all going to be about menopause and also focus about menopause and rheumatoid arthritis specifically. And I know we've got lots of questions already, and hopefully more will come through as we present. So I'll talk about the topic for about 20-25 minutes, and then we'll hopefully dive straight into the questions. A little bit of it initially will be setting the scene, the physiology, and then we'll get to the details of the topic in the second half. So I work at UCLH, that's my main NHS clinic. I do a little bit of work at the Menopause Clinic London at Harley Street, and a bit of research through Institute of Women's Health for UCL University. Conflicts of interest, as I said, I work both for the NHS and the private sector. I do co-found a charity, Menopause Research and Education Fund, and I've conducted a number of GP study days webinars, which have been sponsored by pharma companies. And so those are the conflicts of interest. Now, let's look at the physiology. What happens during menopause transition? And then we'll factor that in as we look at the symptoms, look at the journey of an individual through menopause transition. So the first stage we often talk about is premenopause. This is before hormone changes start. The menopause transition hasn't started yet. Most women will be having monthly menstrual bleeds. Often their estrogen will go through cyclical changes throughout the cycle, but within a normal range. There are hormones from the brain, for example, FSH, LH, which kind of dictate what to do to the ovaries, will be usually within a range which is considered normal. The first stage when often menopause transition starts is the perimenopause. So perimenopause is when hormones start fluctuating. So the ovaries are now making less of a hormone less estradiol, estrogen, which is the key hormone, less ovulations, less progesterone, which is the other key hormone. And these fluctuations can be quite a lot. So on daily basis, on weekly basis, on monthly basis, the estrogen levels can fluctuate wildly. FSH and LH levels also go up and down quite significantly. And as the hormones fluctuate, this is the phase where most women will start noticing some symptoms. For example, they may have irregular periods. The menstrual cycles may become quite frequent, very short, then become quite wide apart, and long cycles. Eventually, the periods will stop. In the meantime, there may be some mood changes, psychological symptoms. There may be flushes, sweats, which are the typical classical symptom, sleep disturbance, joint pains, vaginal dryness or bladder issues may come in. And there may be still other symptoms. There are about 35 symptoms which we will look at. But these sort of symptoms will start picking up around the perimenopause for majority. How long does a perimenopause and the fluctuations go on? Of course, it's usually average 2 to 5 years for majority of women, but there will be some who may have a longer perimenopause or a shorter perimenopause. A few months or a few years, up to 10 years of perimenopause can happen. And for majority, it will be between 40 to 50. That's typically the age when perimenopause sets in. Then comes menopause. So all those fluctuations will eventually become less and less. And then the final period happens as the ovaries are not making much hormones now. The hormones become very little, and menopause happens when the periods stop. And this is usually going to happen between 45 to 55 for majority of women, 90% or so. And it's always a retrospective diagnosis. We only say a woman has gone through menopause or has attained menopause about 12 months after the last period. From this point on is postmenopause. So 1 year since last period when menopause has happened until end of life. That's 10, 20, 30, 40 years of a woman's life. That whole chunk of years is postmenopause. So you can see it's almost more than 1/3 of the lifespan for the woman. Such huge number of years in postmenopause, and we must ensure that women have good quality of life. They're protecting their bones, protecting their heart, giving them good cognitive health. All those are key issues for all those 30, 40 years. We can make a difference. That's why the focus on postmenopause and menopause and rheumatoid arthritis. Symptoms, as I said, can start right from perimenopause, menopause, and continue in postmenopause, and the duration and the severity of symptoms varies between individuals. So no two women will have exactly the same menopause. It's unique. Some may have very mild or no symptoms. Others may have debilitating severe symptoms. Some may have only few symptoms. Others will have multiple symptoms. The duration, average about 5 to 7 years of difficult symptom, but for some, just a few years or months. For others, up to 20% of women, the symptoms may go on for 10, 15, 20 years. We have women who report symptoms even in late 60s and 70s. So everybody's journey is quite unique and different. Again, some women may have medical or surgical menopause. Remember that drugs like chemotherapy or very significant medications can bring on a menopause. Surgical menopause can happen if you're removing ovaries surgically for tumors or cysts or endometriosis. Medical treatments for endometriosis like GnRH may induce temporary menopause. So medical or surgical menopause can happen, and it can happen abruptly. Because remember, with natural menopause, you have many years of perimenopause where the hormones drop gradually. But with medical or surgical menopause, it happens within hours, days, or weeks. And so therefore, it can be quite abrupt. Symptoms can be quite severe and persistent, and something that needs to be taken on board when you're looking specifically at induced menopause. It's often not given the sort of due attention that it needs. When does menopause happen? Median age in the UK, in the Western population, Europe, North America is 51. That's an average, 45 to 55 being the range. 10% of women, 1 in 10, have early menopause between the age of 40 to 45. 2 to 3% of women have premature menopause, also called premature ovarian insufficiency. This is under the age of 40. 1 in 1,000 women will have menopause even before the age of 30. So sometimes women may get dismissed if they present early in life, saying, I may have menopause, and often dismissed, thinking this may be PCOS, this may be stress. But remember, you can have that individual 1 in 1,000 where you can have menopause even under the age of 30. And that's a message to health professionals not to dismiss symptoms. Make sure you're investigating this may not be premature menopause. Ethnic variation is significant. Afro-Caribbean women have menopause on an average about 9 months to 15 months before the average age for Caucasian women. Look at the variation in South Asian women. It's 46 and a half is the average age at menopause, 5 years earlier than Caucasian women. So these women will go through menopause much earlier, will have more impact on their long-term health. So again, important to look at ethnicity and know that some women may be more predisposed to having an earlier menopause than others. Symptoms of menopause transition. And again, I can't put on table or put on graph all the symptoms because there are more than 30-35 symptoms of menopause. But again, we'll look at the most common ones, which most women present with in clinic. So it can be head to toe. There can be headaches or migraines. There can be brain fog, difficulty memorizing things, remembering, low energy or fatigue. Hot flushes, night sweats can be the classical symptoms for many. Sleep problems, not getting quality sleep, waking up frequently. Then there can be dry skin, dry eyes, itchy skin, joint pains or muscle aches are typical. Many women report psychological symptoms, which were often not thought to be linked to menopause in the past. Low mood, feeling heightened anxiety, palpitations that go along with heightened anxiety. There can be irregular periods, especially in perimenopause, until the periods stop completely. And finally, vaginal symptom, vaginal dryness, painful intercourse, and of course, low libido can complicate things from psychosexual health point of view. All those are the commonly reported symptoms, but they're not all exclusive. So there are many other symptoms that women may note. But you can see how many of these overlap with rheumatological condition, including rheumatoid arthritis. There are so many amongst these which can easily overlap with rheumatological issues. And often there may be difficulty in recognizing that some of these symptoms are actually menopause, which are kind of thought to be related to rheumatoid arthritis. And there can be often misdiagnosis or wrong diagnosis or not given any credence to the hormone changes that can often let patients down. So we have to recognize there is a rheumatological component, but there's a hormone component that may be going on for some of these overlapping symptoms. Overall, about 75 to 80% of women experience symptoms, and about 1/3 can have very severe symptoms. And every individual's experience is unique. Again, the response to treatments like HRT, what symptoms present can be quite variable. A specific mention about genitourinary syndrome of menopause. This is not often talked about because of embarrassment or intimate nature of symptoms. But remember, this condition can often go underdiagnosed and undertreated. About 60% of women after menopause who are not taking any HRT can suffer from genitourinary symptoms, vaginal dryness, irritation, itching, soreness, painful sex, bladder symptoms like urgency, incontinence, pelvic floor weakness. They can pick up urinary tract infections easily. And it can take about few years before you see these effects of estrogen deficiency manifest. So for some, it may happen very early during perimenopause. Others can take years before these sort of symptoms manifest. And these can be treated both with systemic HRT or just local vaginal estrogen. Because even for some women taking HRT systemically, like patches, tablets, or gel, they can still have some vaginal symptoms which you can improve by giving a very simple intervention such as vaginal estrogen, which really doesn't carry any major risks with its use. In the UK, how do we diagnose menopause? Is it something that we do by bloods? It's not. It's a clinical diagnosis. If somebody has symptoms of menopause, has noticed changes to their periods, or has noticed typical menopause symptoms at an age which we expected them to happen, you can treat that person with non-HRT and hormonal intervention. You don't need a blood test to diagnose menopause, and that's true for women above the age of 45. Typical symptoms, go ahead with hormonal or non-hormonal intervention. If they're between the age of 40 to 45, for those women, especially if the symptoms are not typical, there may be some value in measuring blood FSH level so that it guides us in decision making, what the hormones are looking like and how the symptoms may be related. Certainly below the age of 40, when we are diagnosing premature menopause, we always recommend to have blood tests because there can be fertility implications or there can be importance of making sure the diagnosis is right, as it has a lot of consequences in later life. So blood tests are useful in women below 45, above 45, not much use of measuring FSH level. You would rather treat the symptoms. What about blood tests in other situations? We do use blood tests sometimes for women on HRT to know if they're absorbing the HRT well. We don't often go by a particular level, but it's often useful if somebody is not responding to their symptoms on HRT. Are they absorbing enough hormone from their tablet, patch, gel, or spray? Or some women may be already be on contraception. They may be taking a progesterone long term. They may be having a Mirena coil. They may be having other forms of hormonal preparations, and they may not have periods. Then how do we know that the symptoms are menopausal? Then sometimes we will offer blood tests, either stopping the medication and then doing the test, or in case of coil or a progesterone implant, you can still do the FSH level, and you'll be able to know whether they've gone through menopause or not. What about impact on long-term health and other body tissues? Of course, not just the quality of life or symptoms are something to consider during menopause transition, but as a woman will go through menopause, there are a number of things changing in the body. First of all, bones. Estrogen is really the hormone that maintains bone density for women. So once perimenopause, menopause starts, in the background, the bones will start losing a little bit of bone density. And lifestyle is very important at this point to maintain bone density, whether it's vitamin D intake, the calcium, the weight-bearing exercise. Heart and blood vessels will change. Estrogen is very good for heart and blood vessels, keeps the bad cholesterol down. So once the estrogen disappears, post-menopause, women's heart disease risk increases because there are changes to cholesterol. Often blood pressure will become high, and there will be changes to atherosclerosis, which will progress. Again, the lifestyle is very key at this point to make sure heart health remains good. Cognitive function, there are some memory symptoms, cognitive brain fog symptoms, which are often reported by women during perimenopause, menopause. For many, they will settle on their own. Others may need help with symptoms. There is changes to muscles because muscles often lose mass and tone. Sarcopenia can happen, which is loss of muscle mass. And again, exercise becomes very important point here besides protein intake. Skin and hair can have changes, dryness of skin, thinning of scalp hair, sometimes excess chin hair or hirsutism can be other changes that are noticeable. And finally, the metabolism. We know that estrogen is a metabolically positive hormone. So as estrogen levels are plummeting, there is often fat redistribution and the metabolism starts slowing down. Often the lean body mass is going away and more of fat is being deposited in areas which are different areas to where it was deposited before, mostly in the central obesity pattern. So the fat redistribution and slowing of metabolism alongside insulin resistance are all the changes that are happening during perimenopause and menopause transition. But what about rheumatological symptoms? How many women note those? Musculoskeletal pain, arthralgia, enthesitis, myalgia is all reported in about 40 to 60% of menopause women. And in about 1 in 5, it's the predominant menopause symptom. So people are now getting more attentive to these symptoms. and paying attention that women can have significant musculoskeletal symptoms as part of the menopause transition. There has been a very recent paper on musculoskeletal syndrome of menopause, as it's called now, and certainly have a look at it if you'd like to read more details on the topic. Menopause needs to be considered every time we think of any rheumatological consultation in a woman who is going through menopause transition, because there are issues which can affect pathways and what the patients get in terms of diagnosis and treatment options. There was a very nice editorial written by one of my friends, Dr. Zoe McLaren, who works in Liverpool, and Olivia, who is one of the menopause specialists who works down south. And they brought this issue of why menopause is relevant to rheumatology. It's because we don't want over investigation. Sometimes it may just be menopause and being investigated as some form of arthritis. We don't want misdiagnosis. Sometimes menopause is not thought about, and that may be the cause of musculoskeletal symptom rather than the arthritis. There may be exposure to unnecessary treatments if we fail to consider menopause as a cause of symptoms. Often individuals feel unheard, and there are no treatments for menopause symptoms often given which impact quality of life. So for healthcare professionals, the message is we really need to think of hormones in the background while we deal with any rheumatological condition. What are the current concepts about managing symptoms and the long-term health impact? So let's look at what is available. If somebody has significant menopause symptoms impacting their quality of life, and we know it's going to impact their long-term health, what are the options we have? So of course, you have lifestyle modification within the limitations, changes at workplace, making workplace better, nutritional or self-help interventions, alternative therapies. These are things like acupuncture, herbal treatments, homeopathy, non-hormonal medications, and finally, hormone replacement therapy. And the aim of any or all of these is to really improve the quality of life, get rid of some of the difficult symptoms, and then try and improve the long-term health as well. What about HRT? Could HRT be an option? Now, in specific context of, say, rheumatoid arthritis or rheumatological condition, there is very little specific research in terms of HRT and rheumatological conditions, including rheumatoid arthritis. Little good research exists, and there are often conflicting studies, but we know that estrogen can have both pro-inflammatory and anti-inflammatory properties, and that depends on what condition and what cell type we are thinking of. Large majority of women, though, with rheumatological conditions report an improvement in day-to-day clinical practice, in joint pains, in muscle aches, and various other menopause symptoms. So we do use HRT as an option in almost all rheumatological conditions with its pros and cons, and a lot of women do find significant efficacy in terms of menopause symptoms, including joint pains and muscle aches. So that's certainly an option less talked about, but hopefully in future, with better hormones now available, that will be commonly offered than before. So again, there are various lifestyle, non-hormonal, hormonal option. And for the sake of time, I'm going to focus more on HRT here. But in the questions, do discuss if you would like to know more about the non-HRT options. What is different and safer about the modern HRT that we like to offer if someone has significant menopause symptoms? So we have body identical or body similar hormones now. We often combine something called estradiol, which is 17-beta estradiol, a body identical estrogen, and we combine that with two first-line progestrogens, either a natural micronized progesterone or dydrogesterone. These are body identical and body similar progestrogen, much better tolerated hormones than some of the synthetic hormones we used in the past. These are unlikely to increase risk of venous thrombosis. So often the worry is, can these increase venous thrombosis or blood clotting, which is often part of rheumatological condition? And what about the breast cancer risk? So these are unlikely to increase risk of thrombosis the way they are used. They are associated with a lower risk of breast cancer than some of the past HRT preparations we had, which were synthetic progestrogens. We try to give estrogen in the form of patches gel spray for those who would be at risk of blood clotting. So if we use estrogen as patches gel spray on the body rather than oral tablets, then that doesn't increase risk of thrombosis or blood clotting. Similarly, if we give vaginal estrogen just for the bladder or vaginal symptom, that does not increase risk of stroke or blood clotting, even in women with risk for blood clotting. So any of the patches gel spray pessaries are safe from thrombosis point of view. What about the risk of blood clotting generally with HRT? So if there is known risk factor for thrombosis or blood clotting, which we call venous thromboembolism, VTE, including there is personal history of thrombosis or there's a family history, then we often will say use estrogen as a patch gel spray, don't take oral tablet, and then you can combine it with the body identical progesterone as a capsule, or sometimes have progesterone as a coil, as a Mirena coil, or some other form of progestogen coil, which is approved for this use. It's unlikely to increase the risk of thrombosis. And it's always important that if there is significant risk, we often involve the hematology, somebody who specializes in blood clotting, in case we are prescribing HRT. But HRT can be safely used in that setting. What about HRT breast cancer risk? This is often the worry for many women who want to consider HRT. Remember, most data now show that estrogen on its own is associated with little or no risk of breast cancer. In fact, the biggest study that happened, something called WHI study, long ago suggested estrogen on its own does not increase the risk of breast cancer. It's only when you take the combined hormones, estrogen, progestogen, those are the ones that can slightly increase the risk of breast cancer. So who can take estrogen only? Anybody who's had a hysterectomy, the womb has been removed, can have estrogen only HRT. But for all other women, if there is a uterus still in place, hysterectomy hasn't happened, you've got to combine estrogen with progestogen. That's when that very little increase in breast cancer risk can happen. How little is the risk? Is about 0.1%. It's about, say, 5 in 1,000 over 5 years. So 1 in 1,000 every year, about 0.1% risk. And for majority of women, if there are significant symptoms of menopause, the benefits far outweigh that risk. So the risk of breast cancer will relate to how long you take HRT, and it will reduce after stopping HRT. What do menopause guidelines say? At the moment, we know that estrogen benefits sarcopenia or muscle mass. HRT has been shown to have significant protective effect against osteoporosis and fragility fractures. In fact, the recent national guidance on osteoporosis guidelines suggests that HRT should be one of the first-line treatments in women up to the age of 60 who are presenting with osteoporosis that needs treatment alongside non-hormonal options. If you look at the NICE guidelines, again, they reviewed a lot of randomized controlled trials, which are gold standard studies, and HRT showed a significant reduction in risk of bone fractures, important again for bone health. And therefore, it's being considered as one of the first-line therapeutic intervention for osteoporosis. What about the other benefits? Of course, there are quality of life, bone and heart benefits. So HRT started within 10 years of the onset of menopause, protects heart, and has some small effect of protecting blood vessels and heart and preventing cardiovascular disease. The effect is small, but nevertheless is there as compared to starting HRT late. Now, what about menopause and rheumatoid arthritis in specific? And then we'll finish with this slide. So rheumatoid arthritis is more prevalent in women than men. We know that. Women are 4 to 5 times as likely than men to develop arthritis under the age of 50, twice as likely between 60, 70. Onset of symptoms typically happens around 45, 55, and hormones are implicated in etiology. And it's the changing hormone levels that seem to cause the flare-ups or onset of symptoms for many women. So for example, postnatal period after the childbirth, perimenopause or menopause often tends to be a trigger for flare-ups or onset of symptoms. What do we know in terms of the age at menopause? We know earlier age at menopause and early estrogen deficiency seems to increase risk of developing rheumatoid arthritis. The impact will vary. For some, whenever menopause happens, rheumatoid arthritis symptoms will worsen. For others, it may not be the case. And we don't understand why these small differences happen, but they do. Studies show mixed results regarding rheumatoid arthritis and hormone therapy. We don't have conclusive data. We need better observational studies or research studies looking at the role of HRT in rheumatoid arthritis. Small studies show benefit from estrogen, but there are some conflicting data and the research is vastly lacking. Lifestyle interventions have to go alongside HRT if it's considered. So again, eating healthy, regular physical activity, not smoking, alcohol in moderation, sleep hygiene, equally important, even though you may be considering HRT. A couple of studies, and then we finish. One study about hormonal reproductive factors in relation to risk of rheumatoid arthritis in women got a lot of attention last year. And they tried to look at various reproductive events and the lifespan in terms of reproductive events and what could be linked to a risk of rheumatoid arthritis. Several factors were associated with the risk of rheumatoid arthritis. The increased risk was noted with, say, onset of periods after the age of 14, menopause happening early below 45, women having 4 or more children, and those who had had a hysterectomy, oophorectomy, again kind of linking lack of estrogen earlier in life with rheumatoid arthritis. They suggested increased relative risk of women developing rheumatoid arthritis associated with use of HRT. But remember, it's an observational study, cannot establish cause and effect. Rheumatoid arthritis in women, one should be offering option of HRT as needed for symptom relief. And this was a big systematic review looking at various studies and combining the result, menopausal state and rheumatoid arthritis. And again, the conclusion was women who have early menopause have significantly higher odds of developing rheumatoid arthritis. So there you go. Often the lack of estrogen early on seems to be linked to rheumatoid arthritis. So in summary, we need to talk more about impact of menopause. While we treat rheumatoid arthritis, we really need to concentrate on what is happening to hormones in the background. And if we can take away some of the symptoms and improve quality of life, we should be offering both non-HRT and HRT options. Menopause is just one phase during life course of hormonal ups and downs for women, but we need to recognize that this may be happening in the background. Since some of the old studies, which got a lot of negative publicity for HRT 20 years ago, now we have better, safer hormones. A lot has changed, so we can offer it to some women with complex medical issues because you have got safer hormone types. Much more research is needed. There are very good patient groups, and there are very good research groups which are trying to now focus on rheumatoid arthritis, and hopefully we'll have lots of more data in future. But in the meantime, remember, if you had to offer HRT for women, benefits outweigh risks for majority, and it's important to have that individualized decision for women, which is really the key. So with that, I'll stop here and not take any more time. We'll dive straight into questions. Thank you very much for joining today and listening.
Thank you, Vikram. That was hugely informative, and thank you very much again for your time in presenting that to us. I think one of the things that really strikes me is this line about a third of our lifespan could be spent in poor quality of health. And so part of what we're doing at NRAS is trying to arm our service users with the information that will enable them to go confidently into seeing either their GP or their rheumatology department to say, look, could it be this? And if it is, can we try HRT? I mean, totally, we understand that it's an individual situation for everyone, and sometimes it's a bit of, you know, testing things to see whether they improve. But yeah, it's quite a big thing to hear you say there's a third of our life that could be spent in poor health. So thank you. Let's hope we've helped provide some information to people tonight so that they don't have to be in that situation. Right, questions. We have got quite a few, and I thought that we might start, because we've had a couple, talking about HRT, RA, medications and supplements. So let me see. We have got a question here about Does having a weakened immune system mean that HRT doesn't help as much? So therefore, is it advisable to take vitamins and supplements to help? And we had somebody on the comments as well, Vikram, that was talking about the fact that they were taking HRT, they were on methotrexate for that RA and taking a couple of other supplements, but are worrying about the thinning hair. So whether you have any thoughts about that as well.
Okay, so you don't necessarily have to take any specific supplements in terms of other than vitamin D. That's important for your bones. Most of us will have low vitamin D in the UK. So exposure to sunlight is limited and often vitamin D supplement is required. Have good calcium in your food. Magnesium is one of the supplements which can sometimes help with sleep for people with or without HRT. So that's something you could consider. In terms of other vitamins and supplements, unless you're deficient, say for example, some may do blood tests for zinc, vitamin B12, folate, and unless you're deficient in this, then you don't have to take extra supplement. If you've been asked to take folic acid as a supplement for medical issues, then you can. But menopause-wise, it's really vitamin D and magnesium, which are the supplements we recommend. In terms of HRT, it affects you in the same way. There's no disadvantage if you have a weakened immune system. HRT should still be able to give you good relief from your symptoms of menopause. If it's affecting hair, then it should be able to help with that. All you need to check is you're getting the right HRT, you're absorbing the right amounts of hormone from the preparation you are on, you're not using a progestogen that could cause some scalp hair loss. So make sure you're using the right HRT. But supplement-wise, nothing extra other than the ones I have mentioned.
Brilliant. Thank you so much for that. If someone's arthritis improved during pregnancy, so is likely to be affected by hormones, does that mean that HRT during peri or menopause might also improve RA symptoms?
It's a good question, and the answer is probably yes, but not always. So if you did feel that in pregnancy the surge of hormones got your symptoms to be better, then it's likely that when you become menopausal, you may have some symptoms coming back or sort of flaring up. In which case, if you have HRT, it may actually mean that you have a better quality of life and less symptoms. However, it's not a consistent effect for everybody. So some people will feel that, others may not get the same effect. There are individual differences in response to HRT, partly because of the nature of receptors and a few other sort of physiological differences between people. So always try it. If you think it will be something that you want for your symptoms, when you try it, a trial of 3 to 6 months, you will know how much it benefits you. And if you feel better like you felt when you were pregnant, that's something that you should carry on with.
Thank you. We've got an interesting question from Bouncy Cat. Is microdosing of estrogen suitable for reducing inflammation? I have to say, I've not heard of that before.
No, so there have been concepts like this which are often seen on internet or some health professionals have talked about. Currently, this wouldn't be recommended. If you're taking HRT, you should be following the standard licensed doses. Start with the lowest dose, which is effective for you, and then stay at a dose that's effective, even if you go up little by little. Microdosing is something that we don't have very much evidence for. One would stick to the licensed good HRT dose and not deviate from the evidence as far as possible.
Brilliant. Thank you for that. So the next question we have is about RA treatments and how they interact with HRT. So are there any treatments such as DMARDs, biologics, JAK inhibitors that HRT should not be taken with?
No, you can certainly combine HRT with almost all of these medications, and you can safely take it. So remember that the type of HRT, the dose, mostly it will be transdermal because of medical risks, and often transdermal estradiol with a natural progesterone or progesterone in other form as a patch or a coil will be completely fine to take alongside all of these rheumatoid arthritis medications. So if you're going to benefit for it for quality of life, certainly it's an option for you.
Brilliant, thank you. We had quite a few questions about bone density, and I know you did quite a big section on that in the presentation, but just whether there's anything else that you can add to this. How do the menopause-related changes in bone density impact joint health in people with RA, and how can we combat it?
There's no specific research I have come across specifically in RA and osteoporosis in relation to HRT. All we know is hormone replacement therapy, because it contains estrogen, is very good for bones, whether it's bones at the spine, whether it's the hip, and the skeleton as a whole. And often it would be a first-line intervention. So if somebody is developing osteopenia and they cannot manage it with lifestyle, the exercise levels you can achieve, or let's say the vitamin D calcium is not able to maintain that osteopenia, there are additional risk factor, or you're already now progressing to osteoporosis. In those situations, you either have non-hormonal or hormonal options to make sure you don't worsen osteopenia or to try and reverse or treat osteoporosis. HRT will be one firm option, and if that's not suitable, you'll have the non-HRT option. So it's very good for bones. Whether it's RA or otherwise, it would still be indicated for treatment of osteoporosis as an option. But again, you have to weigh up the benefits risk, because as I said, the benefits are bones, quality of life, heart, but the risks can be breast cancer or thrombosis, or sometimes endometrial ovarian cancer if the right form of HRT is not used. In those sort of situations, the balance is important, and you make a decision which one is right for you.
Okay, thank you. So we had quite a few questions prior to tonight around potential misdiagnoses, especially when you talk about, you know, people with RA potentially have an earlier onset of menopause. So this is kind of a nubbins of the question. I was diagnosed around menopause. Could the drop in estrogen have been as a result of inflammation or as a result of menopause, and therefore could I have been diagnosed with RA incorrectly?
Well, it could be that both pathologies happen simultaneously. So remember, what we know is if you go through menopause early, it increases your risk. So the drop in estrogen could trigger a cascade pathway that could mean that you flare up with RA symptoms or get diagnosed for the first time. That's one thought. The second one is, because the two are linked, the early or premature menopause and the RA, there's some immune pathology in the background which is causing both conditions. It's causing the rheumatoid arthritis, but it's also an autoimmune cause for attacking ovaries. The antibodies are causing ovarian inflammation, and that's why you go into early or premature menopause. So either the POI itself could be triggering the RA, that's why you see the higher risk with early menopause, or an independent background immune pathology could be fueling both conditions, which is why they manifest side by side. So that's the thought currently. And often that's why it's important to look at what the symptoms are. Are symptoms typical of rheumatoid arthritis? Are symptoms happening with change to menstrual pattern and the joint symptoms? And how much is the overlap between the two? Because you may have to treat both, or if you think one more than the other, start with treating the first pathology. And if symptoms are not better, treat the second pathology. That's how you look at it.
Brilliant, thank you for that. I think one of the things that struck me when we held the focus group to start putting the menopause booklet together was that a lot of the women that attended told us they were managing their RA flares or bouncing back from their RA flares quite quickly and simply, but once they hit menopause or perimenopause, they were really struggling bouncing back from a flare, to the point that quite a lot of them ended up changing their lifestyle quite dramatically in terms of changing jobs or retiring early or that kind of situation. So it's a interesting combination, but I think the thing is we're not to ignore either one of them.
Correct.
Okay, brilliant.
And the point there is, you will have women, I certainly have women in my clinic who found RA worsened during menopause, have considered option of HRT, have felt significantly better since going on HRT. But I also have women who tried HRT, didn't work for them, and then they came off. So you can see the individual variability there. All options on table. The one that works for you is really the key one.
Brilliant, thank you. So you've kind of touched on this a little bit, but I just wonder if there's something more here, because it speaks to quite a lot of the comments again that we've had about talking to GPs about RA and menopause. So can women on an anti-TNF receive HRT, and what form of HRT? As GP their GP is really scared to handle anything when you've got an autoimmune disease. And again, that came across in the focus groups, that once you've got this condition, that your GP is afraid to prescribe anything, and you end up falling between two stools when it comes to trying to get someone to basically help. So I'd be interested in your thoughts about that.
And it's a common experience, sadly. So I think when you speak to your GP, be reassured that you can be taking HRT. It doesn't matter even if you're on some of the medications, including the TNF medications, anti-tumor necrosis factor. Any other medications, as we talked before about DMRDs and other medications, remember HRT is an option there. You go for the lowest effective dose that works for you. Generally, we recommend transdermal estrogen because often if there are medical issues, that's the safest one, but you can combine it with a more of a less androgenic progestogen, as I talked in my slides, but you can have the option. It's not ruled out just because you have an autoimmune disease or you take some medication. It's always about balancing the benefits and small risks that come with it.
Looking at some of the other collection of questions that we've got here, a lot of people are asking, how do you talk to your physician about what you think is an RA symptom versus what you think is a menopause symptom? Because we have lots of women who've asked us, I have night sweats, but I know I can get night sweats from the methotrexate. Or, you know, we had the lady earlier that was talking about the thinning hair. Could that be menopause, or is it a side effect of the RA drugs?
So again, sometimes it may be impossible to separate the two because there is so much of an overlap and the two conditions happen together, in the sense that menopause transition is happening in the background and you have to deal with the rheumatoid arthritis as well. And the two can cause exactly the same. They may be combining in terms of effect on your symptoms. So I often say is, if you have had treatment for rheumatoid arthritis and you're experiencing symptoms of menopause, such as the flushes or the sweats, or the fatigue which doesn't go away, or the skin and the hair changes, or any other, often see if that's happening alongside menstrual changes. That will be a typical sign these are menopausal symptoms because they are happening alongside some of the menstrual changes. But even if they're not happening with menstrual changes, let's say you're already menopausal and you start developing them over time, then if you are treating your rheumatoid arthritis and some of these symptoms could be menopause, they are overlapping, have a trial of HRT or have a trial of hormone replacement in a very low dose. And that often will differentiate which symptoms were because of the actual hormone depletion and which symptoms could still be persistent because they are more of your rheumatoid arthritis and not hormone linked. So often if clinically we cannot determine a symptom is because of RA or because of menopause, but they seem very similar, often a trial of hormones will determine whether that symptom can be addressed with hormone replacement.
Okay, fantastic. And this is an interesting one because we've got quite a lot of questions from a range of young women right through to older women. At what age do people stop taking HRT, Vikram? Or do they?
No, so there's no arbitrary limit as to when you should stop HRT. Once you start HRT, let's say you started it for premature menopause below 40 or early menopause below 45, then we often say take it at least till the age of 51 because there are lots of bone, heart, brain benefits and quality of life benefits. Very little risk. The breast cancer risk doesn't apply until you get to the age of 50, 51 there. After 50-51, we do an annual review. If you're benefiting for your symptoms from HRT, we know it's protecting your bone, then we will do an annual review, look at your benefits, any change in medical history, anything that puts you at particularly more risk, or are the benefits still outweighing the risk? And you can continue into your 50s, 60s, or even longer potentially, as long as you and the health professional feels that benefits outweigh risk. Now, most women use HRT for 10, 15 years. After 50, by 65, come off gradually and then stop HRT completely. Others, few, may continue in their 70s and 80s. The trouble we have is we don't have a lot of data after 65 or 70 because traditionally HRT wasn't offered beyond that age. But as we now learn more, hopefully in 5 or 10 years, we'll have that data as well.
Brilliant. Thank you. So there's a lot of challenges in the NHS at the moment, and getting access to both your GP and even your secondary rheumatology team can be a challenge sometimes. And we have the advent of patient-initiated follow-up being implemented in rheumatology. So this is where a patient might be stable and therefore will contact their team if they need to be contacted. But with the pressures that are going on in the NHS, nurse-led advice lines are quite difficult to get in touch with. So getting into your GP is probably more likely than getting in to see your rheumatologist or speaking to your rheumatology nurse. Is there a particular couple of sentences or lines that our service users and the people watching tonight could use with their GP that would get the GP to take it seriously?
Yes, I think most health professionals want to help you. Sometimes they may not be absolutely up to date, for example, with the latest HRT guidelines, but they still will want to help you as much as they can. So I think mentioning that I feel that some of my symptoms are menopausal, and actually that I know I have rheumatoid arthritis, but this feels different. I have tracked them over 3 to 6 months. What's often important is to track them. If you can maintain a small diary on your phone, in an app, or a small diary that you write your symptoms on a daily or a weekly basis, and you can see a trend that they happen at a time when you don't expect, they happen in a particular pattern, they are linked to your menstruation, or otherwise they seem to be at different times when you don't expect the rheumatoid arthritis symptoms to happen. And if you see that pattern over 2-3 months and present to the GP saying, this is what I have tracked, I feel these are hormone related, could I simply have an option to see whether the hormone related symptoms can go away while I continue down my treatment for rheumatoid arthritis? I think that will make it clear that you've done your research, you come prepared. Sometimes in the past we've said even carry a NICE guideline with you, because the NICE guideline is so useful, tells avoiding unnecessary blood testing, offering HRT as a first line rather than antidepressants for many symptoms. So even if you want to carry your NICE guideline, that's fine. Otherwise, carry your list of symptoms, specifically tell you're cued, interested in taking care of hormone symptom. I think your GP will be able to help or seek advice and help you.
Brilliant. And what we'll add to that, Vikram, is when our booklet is published in the new year, please take a copy of that with you, in with your NICE guideline to speak to your GP. And just a reminder to everybody, we provide a helpline between the hours of 9:30 and 4:30, Monday to Friday. So you're more than welcome to pick up the phone and talk to us and talk through the advice that we are giving for menopause and RA. And maybe prepare your discussion with the GP. So that's another thing that you can do. But also, when we launch the menopause materials in the new year, we will have some dedicated pages on the website. And what I will do is I will ask the team to put in some kind of statements and sentences that people might think about using in order to be taken seriously by their GP. That would be great. Well, Vikram, we've actually come to the end of our themes on the questions. So I just want to say thank you so much for taking time out. I know you've had a very busy day today, and that you came to do this presentation tonight after doing another set of training this afternoon. I'm very much looking forward to meeting you in the new year to say thank you very much for taking part. And thank you everybody for taking the time to spend with us this evening. The video of this will be on YouTube. How old-fashioned am I? The video. The film will be on YouTube for people to rewatch. Please do share it with anybody you think that it would be beneficial for. And thank you again, Vikram. Lovely to see you.
Pleasure is mine. Thank you so much, everyone who joined. Thank you.
Bye.